is a huge question because the factors that contribute towards good health go beyond having someone to come to the doctor on a regular basis. In fact, there are only about 10 to 20% of health outcomes are actually due to the provision of healthcare alone. And so that's something I think that many people think that just because I don't have a doctor doesn't mean that there aren't things that I could do in order to work on health.
As Dr. Miller said, this is a big question. And in the public health space, you'll often hear us talk about things that are modifiable and non-modifiable, things that you can change and things that you can't change. You often cannot change your genes. You can't change the fact that you were born. You may have been born predisposed with a genetic predisposition or at an elevated risk for certain conditions. And sometimes, though, we're very careful in the public health space to say you can even control things like what you eat, because we can say that you can control those things to a certain degree. But if you live in an area that is food insecure or food desert, you don't have access to these food, is that really something that you can control? One of the things that we are really encouraging people to do right now is to seek access to primary care. I know that sounds like a small thing, but what we like to say is that having a provider, a doctor, a nurse practitioner, or a physician assistant that knows you and knows your family history and your background can be really important to let you know what things you can do as an individual to ensure that you are safe and protected. And I think the individual response is also something that's very important right now as we talk about COVID-19, right? Although we talk about social distancing, and we do realize that it's not always possible to be socially distant. It's not always possible to be 6 feet from someone if you live in a small apartment and there may be multiple people in that apartment. But then there's things that you can do, like washing your hands, if you have access to a face mask, wearing that mask. But that question is really challenging, because it talks about individual things that you can do. And that's really one of the things that we say is having access to a primary care provider, making sure that you know your health history and anything that may make you at an elevated risk, and protecting those around you, especially as it relates to COVID-19. And this is a nonpartisan statement, but you've seen how good policies can move the needle already. The fact that in Illinois, our governor released some of the restrictions through state Medicaid funding that would normally require you to go to this particular doctor if you're in a particular plan, right? But in response to COVID-19, we saw some short-term policy changes that said that you have the ability to go get tested wherever you need to go, wherever you can go, you should go and not have to worry about the ability to pay to get that testing. That was a policy change that came down from the state level. And that's one, and that policy change was driven by the needs of the community. Another policy change that I'm hoping that we can move forward to is really thinking about what we talked about earlier, these social determinants of health. As health systems, many of us are assessing our patients for these social determinants of health, but I'm hopeful that we can move to a policy shift where it's not a good thing that we do that, but that it's a required thing that we do that. So that every patient that comes to our door, we're asking them questions about food insecurity, housing insecurity. And not only are we asking those questions, but there's policies in place to actually navigate those patients to the resources. It's not enough just to say, are you food insecure? Do you have the appropriate housing? If you answer no to those questions, there should be policies in place that can navigate you to those resources.
When I think about having culturally competent interventions, I think about who's at the table making decisions about what that intervention is going to be. Because sometimes you have an institutional perspective on why obesity exists in neighborhoods, why there are higher rates of diabetes or hypertension in neighborhoods. But there may be a disconnect between asking the people who are there about their lifestyles and what they think can help move the needle on their overall health outcomes. So when I think of cultural competency, I think of engaging the people that you serve in the intervention that you're trying to do within their neighborhoods. And that's certainly some of the work that's happening with the mayor's rapid response racial equity team. They are bringing community-based organizations and residents to the table to help shape what the interventions will be for COVID-19.
Arlene, if I could piggyback on that just real quick, I'm so happy you mentioned that who's at the table, because representation matters. I've seen Dr. Miller firsthand. I've referred people to her because I knew that once they got in her clinic, they would be able to have a conversation where she would say, you have high blood pressure, hypertension, you may have sugar, you have diabetes. And it wasn't trying to have a conversation that was belittling. It was having that conversation at the health literacy level where people could understand and then also not feel judged, and also having someone who understood what cultural diet looks like and what some of those barriers may be to following some of these dietary guidelines. All that leads to representation. And to your point, when we talked about developing a community response to COVID-19 in South Shore, it was important for us to talk to the community residents, because if we just had the academic or the academic medical center response, it's a unilateral response that would inadvertently miss something.
If you're thinking about some of the health effects versus some of the community effects, there it could go in a couple of directions. And so I'll start with the health effects first. 80% of people, as far as we know, who have COVID-19 will recover from it and will not have any untoward health effects. We are starting to see a few health effects around both heart issues, as well as some people with either lung issues or kidney issues who have more severe infections. We're still waiting for long-term data on this, just because it's what's called a novel virus or a new virus. And so we won't know about that kind of data for the long term. In terms of the community impact on this, when I was a little girl, I heard the expression from my grandparents, when the white community catches a cold, the African-American community catches pneumonia. I have heard elected officials talk about this over the past few weeks within the context of COVID-19, and I think that it's very true. When we think about the opportunities for small businesses to survive, when we think about community resources, et cetera, they're going to be stretched to the brink as people start getting into positions in which they're losing their jobs. They may have someone in their family who is the main breadwinner, who is considered to be one of those frontline essential workers that gets sick. And so we'll have a cascade of impact on communities and families based on the way that COVID-19 has affected their personal situation. And it's going to put a stretch on many of the resources that we have in our communities. I think that one of the reasons why, and this goes back to something that Dr. Watson said just a little while ago, being proactive in engaging in these kinds of academic community partnerships so that we can try to come together to figure out ways in order to provide better support for people during this time, I think is a way to approach it, along with some policy guidance and direction and support from our elected officials.